This is really a somewhat political talk. It's a little bit about sort of state of the nation and some of the challenges that are happening in the TAVR environment and rolling out systems. All right, so a lot of centers like ours have sort of these strategic goals. What does the system of hospitals want to do? So these are the goals for this place, for Methodist. So they talk about safety and quality and service, readiness for the future, community presence, transformational clinical programs, and system integration. These are the big hot button items that, at least in this year, they want the system to focus on. And one of the things they've talked about is how are we going to do this in TAVR? So real simple algorithm. This is the algorithm that we all use for TAVR. Severe symptomatic AS, what's the risk strata, extreme, high, low, and then what do you do? So this is not really contemplated or not really challenged anymore. But you have to have a process. So it isn't enough to simply say there's AS, do a TAVR. It's actually those involved or know it's much more complicated than that. There has to be a flow, there has to be a defined process with clinics, imaging, team conferences, procedures, and follow-up. There has to be a quality sort of effort that's running along in parallel, making sure that everything that's supposed to be happening is happening. There's marketing, and ultimately there's a financial review. So that's all the stuff that sort of has to crank along in the background. We've learned, in the last many years at centers that have done a significant volume, have learned that it really has to be absolutely a program. No single physician can do it, and it's a multidisciplinary team that really makes it successful. So this is a snapshot from one of our weekly TAVR meetings a few weeks ago. This is sort of the Monday afternoon sit down, all the people in the room that are running the list of all the patients that we're discussing. And if you just get a look at the sort of specialties in the room, valve clinic RN, another RN, and interventional cardiologist, cardiac surgeon, interventional cardiologist, a fellow interventional cardiologist, research coordinators, and RNs. And this is not a particularly busy day. In fact, this is a very average day. Some days there's more. So it's a big team that's sort of going through this, particularly when you're balancing clinical trial involvement as well. It makes the team a little bigger. So who is the team? The team is cardiac anesthesiology, whether they're involved with TE or not, and they're sort of making decisions around the level of sedation, but they're critically important for both the simple and the complicated cases. The echo team, and I'll speak a little bit more about that in a minute. Vascular specialists, whether you're doing a planned cut down or an emergency cut down or resolving some complication that you didn't want to occur. And then you need all the post-implant care. Obviously the cardiologists, the nurses, all the technologists involved, the fellows. So it's a big enterprise that it really affects the entire heart center. So the bigger team, as you sort of get out of the procedure room, you've got all the cath lab personnel, the OR personnel, the ICU team that has to know what a TAVR patient looks like when they get there, if they get there, the geriatricians, the nephrologists, the neurologists. So everybody sort of learns what the TAVR program is. Hopefully they learn it early and not late. And then there's these sort of classic slides that are out here. Well, why do these teams struggle? So it's not easy to do this, but it's a pretty clear list of the reasons why people don't do well. So they want the team-based results, but they don't want to create the team. That's a reason to fail. Overestimating the importance of the task. They just want to get the valve in, and underestimating how important it is to have a process to do the evaluation and the patient selection. A system or a culture that doesn't really encourage collaboration and cooperation, that is a recipe to not succeed. Still believing that, well, I'm very good at this one thing, I can do this myself. I don't need, other centers build teams, I'm a team. That tends not to work. Neglecting all the talent that exists within your institution that can contribute when usually that does exist. And then really not enough training. And the training, as you've heard a little bit about this morning, really can't be overemphasized. And what I'll show you is a little data about volumes and quality and how much training matters. So this is a document that's been out almost 10 years now. It was initially compiled when TAVR was still in trial settings before it even went commercial. Sort of a survey of multiple high-volume valve centers, sort of looking at some of the best practices. What are the places that are doing a good job? How are they putting it all together? And this is sort of the short list of the bullets that they came up with, the sort of the recipes for success, not for failure. So physician leadership that's passionate for the valve care, a core team of professionals, a dedicated space, so typically the valve clinic concept, an established day. Whether it's 1 day or 2 days a week, but a day of one-stop shopping so your referred patients can get a lot done in one day. You need a lot of hospital support. If it's a physician-only mission, without the administrators really knowing what they're getting into, that's not going to succeed. You have to have a capacity to review a lot of complex cases. Not everybody shows up and they're clearly an appropriate patient for TAVR. So some mechanism to discuss complex cases is important. And you got to have a comprehensive communication. So that's to the referring docs within your team. I can't say how important that is to actually let everybody know what's happening. And the communication solution is different for every place. So this is just a snapshot of sort of, what we've defined our system to be, or at least our TAVR program. We certainly have a valve clinic, and the valve clinic has a lot of different components, navigators, the physician attendants, the schedulers, all of the support that the clinic requires. There's the TAVR as an actual process that is also acknowledged within a sort of a greater valve program. And that includes everything from the clinic mandates, the credentialing, the outcome reporting, the patient selection, that all falls within TAVR. And then there's the greater valve program effort, which includes communication to referring docs, the registry compliance, financial review, the marketing. That's sort of the bigger sphere. And if you look at TAVR specifically, there's actually some discrete phases. So, there's the phase of patient selection. That's the valve clinic, the valve conference, all the diagnostic studies. That's sort of the front load. There's the stuff in the middle where you actually have to, choose patients and procedures. And then at the end, there's all the stuff at the end that people sort of easily forget about is the outcome assessment, the referral back to the valve clinic. How are they doing it at 1 month, at 12 months, at 5 years? And then you've got to let the TCT and others know how you're doing. So that's a lot of effort on the back end as well. So those are all the different phases of the TAVR team participation. So in 2018, there's still some challenges, right? So the patient selection is actually not getting easier. In fact, if anything, it's getting harder as we sort of look at, we don't eyeball necessarily the extreme risk patient anymore. Now we have to deal with things like low flow, low gradient, low risk, bicuspid valve, valve and valve. It's not getting easier to pick patients. Quality of echo performance in AS quantitation is incredibly highly variable. We get a lot of referrals from well-meaning centers who've sent this patient as severe aortic stenosis. And often it is, but too often it is not. There's the national coverage determination, which is basically who decides who gets paid. So if you're going to do this procedure, you have to follow some rules. And what are those rules? Those rules determine who gets paid and who doesn't, and ultimately those rules determine what centers will do the procedure and who won't. And then you've got these system-based models. Often what we have is a hospital-based model, and very rarely is there a good system to move patients around the whole city so that they get the care that they need. So these are some of the challenges today. So one of the things that's come through over the course of many years of seeing these patients is more clearly identifying who should not go to TAVR. This is actually getting a little easier. So chronic multi-system failure, significant debilitation despite the aortic stenosis, not because of the aortic stenosis. Significant mental impairment. Often the patients show up in clinic with their family and they're acknowledging the dementia, and they all think that once the blood flow is improved, the dementia is going to get better. And we have never seen the dementia get better. And so there's unrealistic family expectations at times. So there's a pretty well-defined list of who doesn't benefit these days. So, this is the question I like to ask is sort of the most important role of the imager on a structural heart team is to do which of the following? To evaluate the PVL after TAVR, to recognize what low flow, low gradient severe aortic stenosis looks like, to ensure that the echo reports contain the data necessary for the complete NCDR, STS, ACC, TBT registry reporting that's mandated if you want to get paid, to adjudicate all things. Is the MR mild or moderate? Is the EF normal or abnormal? Are we done and do we get to go home, or do we have to stay and keep working? And the answer, of course, is kind of all of those things. So the imager on the team is somewhat embedded and has multiple roles and multiple hats to wear. If you know what exactly paradoxical low flow, low gradient severe AS is, congratulations, because it's not easy. This is one of my favorite mnemonics in all of cardiology, PLFLGSAS. Okay, it's almost as bad as HFpEF. But this is it, so these are the criteria. So this is what low flow, low gradient severe AS looks like. You have to sort of be able to recognize this. Small valve area, small index valve area, DVI that's low, a mean gradient that's low. But the valve still has to look abnormal, has to be thickened and calcified. There's some ventricular components there, impaired filling, low stroke volume index. So it's not a trivial thing, and it's not a casual thing, and if you're reading echoes a lot and thinking about these patients, this is easy to wrap your head around. If you're not looking at echoes on a regular basis and considering these criteria, it's easy to not identify these patients. So this is sort of the current state. The imager is sort of in the foxhole, fully embedded with the interventional team. So you're part of the team. You got to be familiar with the clinical evaluation and management of structural heart issues, special competence in all aspects of TEE, special competence in the procedural guidance. So usually that means level 3 echo and you know all the procedural steps. And then familiar with other modalities like cardiac CT. You know, when do you need a cardiac CT and what's it going to add? So the other thing, you know, for the imaging world to get used to is sort of the risks. And this is a nice study that Alan Lumsden and colleagues did looking at fluoroscopy and the dangers of fluoroscopy. So this is, you see the IIs in the AP direction, and the sort of the halo is badness. And as soon as the II gets out of direct AP and gets a little tangential, the halos get bigger and bigger. And for the technologists in the room, you'll certainly appreciate this. And when it goes full lateral, the halo is enormous. And where is the worst halo? It's usually where the echo person and sometimes the anesthesiologist is standing. So this is a concern, and for the sonographers who are going in and doing these transthoracics, this is a level of education that many of us don't have. So this is one of the sort of awareness slides. So the imager does all these things. You're involved in selection of the procedure, selection of the patient, selection of the device size sometimes. You're involved in guidance for the goals of safety, efficacy, and efficiency, and then evaluation. You got to say, how did the device do? Is it performing the way it's supposed to? And is the heart responding in the way that we expect it to? So fully embedded. This is a neat slide from one data set, and it looks at, you know, a lot of community hospitals ask the question if you have multiple opportunities to improve the diagnosis of referrals for AS. So on the far left that's sort of the cohort. Let's call it 100 patients with severe AS by criteria. Well, only 17% of those patients were judged to be mild, 36 were judged to be moderate by the reading physician, 47 were correctly identified as actually being severe. Of that 47, only 20% were sent for therapy, and of that 20%, only 12% actually got recommended for treatment. So 12% of the original 100 in this one study actually trickled their way all the way down to actually get appropriate therapy. And a lot of that is the first 3 bars of correct identification of aortic stenosis. And this was at multiple different hospitals. So they looked at several different hospitals and different systems. The gray here is they truly had severe AS on an echo, and the other bars represent those that were actually referred for treatment, and the red finally is those that actually got treatment out of the denominator that actually had the disease. So there's an issue with patient identification and correct identification of severe AS. And a lot of heart valve programs will have to have these components: surgical excellence, imaging that's advanced, the innovation of catheter-based stuff, and education. So let's get to the current state of the art. So what's the payment look like today for TAVR? So the National Coverage Decision, shortened to NCD, was published in 2013. So it covers the covers the payment for TAVR for symptomatic severe aortic stenosis. But these are the conditions you have to have. You have to have 2 cardiac surgeons that independently examine the patient face-to-face, evaluate suitability for an open repair, and both surgeons have to document their rationale and their judgment for why TAVR would be appropriate. Okay? The patient has to be under the care of a cohesive multidisciplinary care team. So these aren't abstract concepts. These are actually very clearly defined in the sort of the Bible for payment, some consider this. So if you want to start a TAVR program, so if you're a small center, and this is very germane today, there's a lot of discussion nationally about how many TAVR programs should exist in this country and where should they be. Well, today, the guidelines or the document that controls payment says you have to have, to be a new site for TAVR, you have to have at least 50 AVRs done in the prior year to TAVR, including at least 10 patients that were considered high risk. So your site has to be doing at least 50 surgical AVRs to then be considered adding a TAVR program. You have to have at least 2 physicians with cardiac surgery privileges. So if you're one surgeon at your institution, that wouldn't cut it. And your site also has to have done more than 1,000 cardiac caths per year, including 400 PCIs per year. So that's the current state, that's the bar to begin a new TAVR program. So your cardiac surgeon on that team has to have done at least 100 surgical AVRs. and at least 25 in 1 year or 50 in 2 years. You also have to have an interventional cardiologist who's performed at least 100 structural heart procedures, with 30 of them being left-sided procedures, okay? And ASD, PFO repair doesn't count. So a little different if you've already got a TAVR program, but now you want to continue to have a TAVR program, so perhaps your volumes aren't what you want them to be. Well, that matters too. Say one of your surgeons left, for example. Well, do you still qualify? Well, now you have to continue, still have to do at least 20 AVRs a year. You still have to have 2 physicians with cardiac surgery privileges, and you still have to have the same number of CATs and PCIs done at your site. Okay, the heart team has to have a surgeon, of course, and an interventional cardiologist, and you have to have all the additional members of the team, including echo, heart failure specialists, anesthesiologists, intensivist nurses, social workers. Okay? So the NCD registry is also the thing that sort of some people would underestimate the magnitude of the commitment to. The heart team and the hospital both have to participate in this thing, and it's prospective data collection. It's every single patient that gets a TAVR, so consecutively enrolled for whatever device they got, whatever manufacturer, and you have to follow them for at least 1 year. And these are the sample of the outcomes you look at: all-cause mortality, stroke, TIA, major vascular events, kidney events, quality of life, and any repeat valve procedures. And what's important to recognize that this data is publicly reported. So it's not just a secret between you and the TVT. Mortality, significant cardiac events, and you're not just reported your number, you're reported in relation to other centers who see patients that are similar. So you're really benchmarked nationally on your outcomes. This is, classically, this is our institution and sort of showing for the last several years the volume of growth in TAVR. And you can see that since 2011 when we started, we have a slow and steady growth, but it has tapered off a little bit. So there is increasing competition. The rate of growth is decreasing, and more system integration is needed. So this is from TVT. This is nationally. So this is the top dark red is TAVR, and the surgical volume is down here. So about 2 years ago, TAVR surpassed SAVR nationally as the volume. And if you look at how does TAVR break down, of all the sites, at this time there are almost 400 TAVR sites registered, what's the volume like for each one? Well, you've got some sites, a few, doing almost 500 cases, more than 500 cases in a year. And you've got some sites doing probably 1 case a year. And you've got this crazy curve. So 100 sites doing slightly less than 200, but a massive variation in the volumes done per sites. So some really very low volume sites over here. This is an example of our system hospitals. These are the sort of outlying hospitals. Here we are down in the middle. This is the way, we'd like to see some patients come for structural interventions, but recognizing these little triangles are all the other TAVR sites that are in our system. So there's local pressures to have a system that works. This is probably, it projects reasonably well. This is probably one of the most important slides. It's driving a lot of the latest recommendations. And this is the idea that volume and outcome are pretty well associated. So this is looking at 4 parameters of mortality, vascular complications, significant bleeding, and stroke. And if you look at here, the red line is the unadjusted, and the blue is the adjusted mortality. And basically showing that, and this is number of consecutive procedures moving from left to right. So if you look at how many procedures you do, there's a slow and steady decline in your mortality. Vascular, how many procedures you do, a slow and steady decline in your vascular complications. Bleeding, slow and steady decline. Stroke, a slow and steady decline, and then it's just stable. And for most of these, there's an inflection of around 100 cases. So that's where these recommendations come from, that if you can do about 100 cases, you've got the steepest part of your learning curve. After 100 cases, there's still a trend to get even better, but it's not as dramatic. So now this is what's been in press as of this summer. This is a multi-society consensus statement on what institutions should require to do TAVR. So this is in press. I don't think it's out. It's out certainly online. I don't think there's been a hard copy yet. It's chaired by Joe Bavaria at Penn. And this is one of the main concepts, is that, and there are multiple versions of this, but basically this sort of 4 particular spots on this grid. And if you look at TAVR clinical outcomes across the bottom and volume, low, medium, and high. So there are some who have great outcomes with high volume. Most have high volume, high outcomes. There are a few that have low volumes and good outcomes. But really, this is the worst case. You don't want to have low volumes, low volumes and optimal outcomes is a small group. That's a heart scratcher. It's hard to understand how they got that, but they exist. You don't want to have low volumes and less than optimal outcomes. That's what the goal is to sort of have this group not exist. This is reasonable volumes and less than optimal outcomes, also not ideal. So this is really the green. This is the ideal. So reasonable number of volumes with good outcomes. But the principles are that quality is very difficult to measure. Volume is very easy to measure. And maybe volume should be used as an imperfect surrogate for quality. It's not perfect, but it's better than a lot of what we have. So this document sort of goes through and talks about what are the phases of TAVR, what's happened. So there was this early investigative phase when it was all trial-based. Then there was the initial commercial rollout, roughly 2012. A lot of sites growing rapidly. There was sort of an explosion from 50 sites up to 400 across the country. We sort of in 2018 have kind of a steady state. We're not seeing a lot of site growth, but there's still pressures. Now we're over 550 active sites doing some version of TAVR. And then it's sort of one of the challenges are there's still a few sites that only do SAVR and don't do TAVR. There's some sites that only do TAVR and don't do SAVR. And should that be what patients experience? Should a patient walk into a center and get offered only one therapy because that's the only therapy that site does? Or should every site offer both? So this is a fairly complicated document, and I just want to take you through really what the recommendations are, because that's the bottom line. So this is the newest recommendation. This has not yet been formally adopted by the FDA or CMS, and therefore the national coverage decision hasn't yet changed, but the FDA tends to be fairly accepting of multi-society recommendations, and this is the recommendation. So we'll see what actually happens. So the documentation, this is the new criteria that are recommended. So you've got to document, and there's a lot of emphasis on documentation. You can't just say you have a team. You have to document a multidisciplinary approach to the patient, and you've got to discuss all these things: TAVR options, SAVR options, palliative care, medical care, and the patient has to be involved in all this decision-making. You've got to document that you've got an evaluation by both a cardiac surgeon and a cardiologist. And you've got to document that you've got education of the patient and the team around all these issues. This is a change. So one of the proposed changes is you don't need two surgeons anymore in the documentation. So the move seems to be one surgeon who's familiar with this and on the team is enough to make the evaluation. So that's a change. But you still have to have a proceduralist, and that proceduralist still has to have done a lot. So 100 transfemoral TAVRs. Oops, I guess skip one. The institution and the site also matter. So if you are, the institution in terms of its SAVR volume alone, so there's SAVR criteria to be a TAVR site. So the SAVR, you have to have two surgeons at the hospital still, and they have to be at that hospital for at least 50% of their time. Now that's a change. That's perhaps a limitation in a lot of centers. If that surgeon is only there on TAVR day, that doesn't qualify. So 50% of the time is a new thing. The hospital volume is slightly lower, but they still have to do 40 SAVRs per year, which at some centers is getting harder because I showed you that TAVR is replacing SAVR. So you've got to maintain SAVR volume while promoting TAVR in a center that TAVR is hard now. SAVR is hard to do. And you've got to be good at it. You have to maintain STS quality scores of 2+ or 3+ stars, and I won't go through all that detail. So the proposed TAVR surgeon and a new TAVR program, you still have to have done 100 surgical AVRs to be a surgeon of a TAVR program, at least a new program. The other requirements, your site has to have done 300 PCIs, so down from 400. You still have to do active participation in all the registry stuff I mentioned. And here's the tough one, is you've got to maintain above the bottom 25th percentile. If you roll into that bottom 25th percentile for more than 4 consecutive quarters, you will actually lose potentially the ability to keep doing TAVR. So that's an active effort to address the low quality sites. You've obviously got to have all the vascular interventional capacities and pacemaker capacities 24/7. And then basically a lot of focus on quality, specific metrics. So not only the registry participation is the same, you've got to have meetings, you've got to document those meetings. For TAVR, you have to do it quarterly. Your surgical program has to do at least semi-annually. And then you have to actually have a proposed and documented approach to any deficiencies that your team identifies. And you still have to have the same imaging expertise, so that really hasn't changed. So in addition, there's some external factors. That's the TAVR criteria that are being purported. This is just one slide to show. In addition to that, there's another document that I was part of the writing committee for that's looking at creating actually systems of care around valve disease. These are sort of twin documents. This is proposing, much like a trauma center where there's a level 1, level 2, and level 2 would have even more comprehensive capacity. There's a move to sort of credential potentially, or at least identify a level 1 valve center and a level 2 valve center, and try to put some differentiation on what is the scope of valve interventions that a certain site can do. So in summary, perhaps in the next few months there'll be a new national coverage determination for TAVR. TAVR teams generally are associated with better outcomes. Higher volume may be associated with better outcomes. That's still quite hotly debated. Access to care is a big issue. So if you want to go in Wyoming and close down their TAVR site, well, where are those patients going to get their TAVR? That's an issue. And the question is asked is, should a low volume site, potentially a site that is lower quality, be accepted if it means access to care? That's a tough question. Ultimately, payments are going to be linked to publicly reported outcomes, and the professional societies will soon recommend a system of tiered expertise in valve care. And once the societies do it, and once the marketing people do it, the payers will follow. So that's sort of expected. So I'll stop there and maybe answer a question or two. Thanks.
So when we set all this up, Steve, I as a surgeon was required to do a certain number of surgical AVRs, which I really don't think has any impact on my ability to do TAVR, but it might be a surrogate for how good my center is in taking care of cardiovascular disease. And then we had to see 2 surgeons just to make sure that you wouldn't bully one surgeon to let low-risk people slip in when we didn't have risk. Now we're going to get low-risk approved probably. I mean, very likely. Should there be an NCD about surgical AVRs if you're beyond a certain age, 65, 70, 75, where you have to have a cardiologist see you or you can't be approved for surgery, just to make sure we don't go the other way, where people may take somebody who's really much more appropriate for TAVR but never give them the option to discuss it?
Well, what this document does, it's not a surgical AVR document, but they do say the patients being evaluated and referred for aortic stenosis should be evaluated by the multidisciplinary care team. So it's the team is inserted at the AS level before the decision is made for TAVR. So the hope would be a cardiologist is involved in that decision before it goes TAVR versus SAVR, branching point. So that's not covered in this document. I don't know if there'll be an NCD on that, but that's certainly in the spirit of the evaluation. It's care team up front, then a treatment pathway decision. Yeah.
So on these low volume centers, it's kind of fascinating that if you do less than 50 a year, your mortality is doubles. That's certainly not good. Do you think that could be an artifact of,
Do you think these low volume numbers could be partly an artifact of a 1-year sampling period where you get a couple of deaths and you're good and it messes you up just like it does in surgery? And maybe should we be looking more at a 5-year period or something? Because a low volume center that does excellent work is certainly possible. But getting that one-off death here or there doesn't hurt you if you're doing 300 a year like we do or you guys do.
I think what's really interesting is that people there are going to be papers coming out soon that are going to show that surgical volume has no relationship to TAVR outcomes, but that surgical outcomes for your system do as a surrogate for your ability to take care of heart care people. And I think they're going to go from numbers to quality outcomes over a 3-year rolling period. And I think you're right. If you're a low volume, a couple of bad luck in a row, you're in trouble. If you have bad luck in a row 3 years in a row, it's probably not bad luck.
Yeah, exactly. That's what I was thinking. And then the other thing I wanted to mention, which I'm sure you don't have time to go into in a detailed talk like that, but when we also, like you, have everybody in the room, surgeons, cardiologists, everybody. And there's a lot of things that don't fit into the algorithms. You know, the other day we had a lowish risk, you know, bicuspid, but there was a spear on one of the leaflets of calcium. Now we know if we put a balloon and push that, it's going to go right through the aortic wall. And so there are things that you see on a CT, an echo, that when everybody puts their heads together, we say, you know, we're going to do surgery on this patient, or we're going to do TAVR on this patient. And I think I just want to make that comment. I know you guys do the same thing, but that doesn't always get captured in these algorithms very well.
I think it's a good point that, you know, we often use the term TAVR team, but it's really an aortic stenosis or a valve team, because the whole team is deciding on the therapy, and often the diagnosis and the severity of the diagnosis. You know, it's the low flow, low gradient. Sometimes you're bringing in CT because the echo's not clear, and you know, we have a big group in our meetings, and there is kind of this, you know, stop the line mentality. If somebody sees something, it just doesn't make sense. It's easy for the TAVR train to keep running, but if somebody recognizes, like, wait, this gradient doesn't make sense, this person's lung function doesn't make sense, let's just stop this for a second and circle back and look at the nuance of the detail and make sure we're doing the right thing. I think that's something that's very unique to a team, that it's hard for any one individual to do that to themselves. Yeah. All right, thank you.